welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. In this series, we are exploring the world of hematology through conversations with leading experts in the field. Today, we have the privilege of speaking with Professor Martin Dreyling, a professor of medicine and head of the lymphoma program at Ludwig-Maximilians-University, LMU, in Munich, in Germany. He is also a member of the ESMO faculty group for hematological malignancies, the president of the German Lymphoma Alliance, and a member of the executive board of EHA. Welcome, Professor Dreyling, and thank you for being with us today.
Thank you.
So Professor Dreyling is a renowned expert in lymphoma, and his work on innovative therapeutic approaches for lymphoma, particularly in mantle cell lymphoma. So we are here today to revisit your career and understand how did you get to where you are today. So can you please tell us what is your first memory of hematology?
Oh, that's easy. So I first of all have to give a disclosure, which is, my career went all against the odds. So probably I'm not the perfect role model. But anyway, how did it happen? How did I come into hematology? It was rather clear that I did not want to become a hematologist. I wanted to become a cardiologist, and so I was rotating through general internal medicine. During my rotation, I got on the oncology ward, and at that time I really learned that first of all I got very well connected to our patients. And my personal role model was the attending physician who did an excellent medicine, I thought, was really taking into consideration also human aspects from patient side, but also very broadly integrating the therapeutic team, including the nurse staff and so on and so forth. And that is essentially where my starting point was.
So you fell in love with hematology, or?
In Germany, hematology and oncology is together, which is unusual in the rest of the world. So anyway, at that time for oncology, it was rather sobering. You had very few cytostatic drugs. And there, the lymphoma in general were really the inspiring field, because there you had some effective treatments. You could cure patients. And this was a strong motivation. I really got touched by the field of lymphoma and drawn into this field more and more. And that really somewhat broadened my interest in the field.
So you entered hematology through lymphoma from the start?
Absolutely. And then it was not straightforward, because then I went back to the general hospital, went back to university, and at that university hospital in Münster, it was 90% acute leukemias. But that was more or less reiterating my focus in that way, that I was more into the lymphoma, and there is some I would say, emotional aspect to that. That was really, this subject where I was burning for.
So you have worked in different types of lymphoma. Can you tell us what have been your most important findings in different types of lymphoma?
If people hear my name, they probably associate me to mantle cell lymphoma. But then again, this just came by chance. In the 90s, I have been in US working on a new tumor suppressor gene, P16 called at that time, nowadays CDKN2. And we just by chance pulled out 3 cases out of the fridge at University of Chicago and analyzed them. And 2 of these 3 cases had a P16 deletion. And these 3 cases happened to be mantle cell lymphoma. And when I came back to Germany, the head of department at that time said, Martin, would you like to take over on this rare lymphoma subtype called mantle cell lymphoma. And at that time, you have to understand, nothing worked in mantle cell lymphoma. So we started with a phase 3 trial, a randomized trial, and we submitted this proposal to some funding bodies, and they said, you can't perform phase 3 studies because you can't define the control arm. There is none. Nothing works in mantle cell. So that was obviously 30 years ago. Now, luckily, the field has changed, and there were a couple of revolutions. Probably the first part was integration of the anti-CD20 antibody. A lot of today's youngsters take that as, normal, but it was not at all at that time to establish that. Second thing probably was the establishment of dose intensification, and that covers both integration of cytarabine, a drug we know from acute myeloid leukemia, and also autologous stem cell transplant. It's standard first-line study. Again, that had been 10 years ago, and where are we right now? Well, now we cut down chemotherapy. We just go the opposite way. And why is that? Well, the better is the enemy of the good one. And now we have better targeted treatment. And so we were successful to establish a new standard of care in younger patients, skipping autologous stem cell transplant. And I'm privileged to chair a European network focusing on this kind of disease. And this is what I do believe in. Teamwork, working together, does have some additional benefits for all of us.
You're touching on the fact that you have made a big contribution on molecular targeted approaches with inhibitors like ibrutinib, B-cell receptor pathway inhibitors. What can you tell us about ibrutinib and its use now on mantle cell lymphoma?
Well, what I can tell you is how basic science and clinical care gets hand in hand. And that is probably what is still today fascinating for me in hematology. So the first point in mantle cell lymphoma was identifying the cyclin D1 overexpression as a specific marker to recognize these cases. Initially, we misdiagnosed 2/3 of the cases, the majority. And this is in fact based on regulation of cell cycle, and in fact the already named tumor suppressor gene P16. This does also coordinate cell cycle regulation. Meanwhile, we have, for example, compounds who inhibit cyclin D1. The first study had been performed in mantle cell lymphoma by our New York colleagues, but it never took off. The results were good, but then the companies moved on to breast cancer. Another example is, although it's not yet that well established, P16 is one of the strongest prognostic markers in mantle cell lymphoma, like P53. And now we know that these cases probably specifically benefit of the compounds you mentioned, the Bruton's kinase inhibitors. And ibrutinib is the first generation drug, which is registered in Europe for mantle cell lymphoma. And this especially benefits the high-risk patients, the patients with, for example, P53 mutations. So that tells you a little bit how, from wet lab to clinical application, these developments goes hand in hand. And that is what I found very fascinating about these kind of diseases.
Are you using other targeted therapies for low-grade mantle cell lymphoma, or?
Well, it's funny, as you mentioned it. Follicular lymphoma, let's say, is my origin, if you want so. So this is where I started off. And this is the kind of lymphoma subtype which is mostly sensitive to old-fashioned chemotherapy. And then quite a number of targeted approaches have been explored, all of them also in the easy-to-treat follicular lymphoma. And surprisingly, it came up that follicular lymphoma, well, it's not so sensitive to all of these targeted approaches. And in contrast, mantle cell lymphoma, which originally had really the background as an aggressive lymphoma subtype, this was especially sensitive to these targeted approaches. So that tells me the message that you have to remain humble. You do your experiments, you do your studies, you do your research to find out new things, and you have to be prepared for the unexpected.
So you have been lately involved in groundbreaking clinical trials, triangle clinical trial, or now multiplied clinical trial. What can you tell us about this?
Well, triangle is a huge trial, and with almost 900 patients, which is extremely challenging in such a rare disease. And why did we come up with these huge numbers? Well, we're talking Europe. Europe is not speaking with one voice, but with multiple. So we could not agree on the, quote, experimental arm, so what to test. Either ibrutinib plus standard of care, or even substituting for autologous stem cell transplant. And so this is why this huge number of patients came up, and this was only feasible in close collaboration of 14 different national study groups. So this is really all over Europe. And now by these huge patient numbers, we also have reliable data proving the superiority of the ibrutinib containing arms. And these data are so strong that we went back to the company and said, we are so convinced we want to go on to bring that to registration. And exactly this is now going on. And that's for me also the first time ever when we have been so successful that we're moving on from an academic trial to a full registration establishing a new standard of care. And this is where I'm a little bit proud of, but this is not about me. This is about the teamwork that our consortium, because of its size, because of its collaborative nature, we are able to perform these huge studies, and our US colleagues looking at the results. And so I'm very honored that also at this meeting, don't get that wrong, this is the American Society of Hematology. So this is their, if you want, so national meeting. Still, it's more or less the world meeting. They invite the world to present their data, and these results of the triangle trial you mentioned is now being also integrated into the American guidelines, the NCCN guidelines.
So you have mentioned a few times the importance of collaboration. So these trials involve, in Europe, 14 countries. So during your whole career, I think collaboration has been really important. You have been a member of many medical societies, and one of them, EHA. You have been a very active member. How did you get into EHA in the first place?
Again, I already told you in Germany, hematology and oncology is together. So previously I have been responsible for hematological guidelines for ESMO, because they are mostly oncology, so they have no clue on hematology. And this is where I really became enthusiastic about the European cooperation. And then, obviously, my home institution is EHA, very clearly been said. And luckily, I was invited to also be involved in the development of the EHA guidelines. And that's, if you want, so my baby at EHA. And I more and more moved from basic research to clinical research, I have to admit. And I realized that EHA is also very strong in the political field. So I become the chair of the Initiative Against Bureaucracy in Clinical Trials, because performing clinical trials now became so formal and so laborsome. And here I'm talking not about providing safety to our patients, I'm talking about pure paperwork, that it's hard to perform these huge academic trials anymore in Europe. And that is why I also like EHA. EHA is not only supporting research, not only supporting the setup for the next generation, namely young EHA, but also exploring these political aspects and strongly lobbying in Brussels. And this, I think, is the right way, again, going hand in hand, science, clinical education, but also these political initiatives.
So you mentioned that you are a member of ESMO faculty. So you were a member of ESMO before EHA?
Yes, I have been.
Okay. So how have these two things been hand in hand? Because as you mentioned, you're now at the initiative of making the guidelines together between ESMO and EHA. What has been your involvement in both societies?
That's a good point, because I have been the translator to bring these two different worlds together. And in ESMO, I'm the exotic guy because I'm into hematology. Now in EHA, I'm also, with mantle cell lymphoma anyway, you're always exotic. So I live in both worlds. And so I was able to bring these initiatives together. I was luckily able to convince EHA that it's really important to have guidelines. And I strongly believe in European guidelines. They have different functions. Our national guidelines are very much focused on the different national setup when it comes to registration, health system, and so on and so forth. The European guidelines have a totally different function. They also have, first of all, a broader consensus, but also support different countries, the not so well-off European countries. I mean, I'm lucky. I'm living in Germany, which is one of the most wealthiest countries in Europe, to be honest. But we have to be aware, in the southeastern part of our continent, there are countries which are much well off, and for these countries, it's extremely important and helpful to refer to what we assume as really the European standard of care.
How do you see lymphoma research evolving in the next few years?
Well, first of all, I think we are rather competitive here. This is one of the few medical fields where the traditional European strength, the establishment of national study groups, have really led to some huge effort of research, of improvement of medical care, full stop. How is the field moving on? We are moving away from plain cytostatic chemotherapy. Immunotherapy is a huge subject in lymphoma. This is the first broadly introduced gene therapy in medicine with CAR T cells. So that's really, very innovative also. We take this just for granted. No, it hasn't been there a couple of years ago. Secondly, we are moving into the field of targeted therapy, which is so efficient that it's not only better tolerated, but it's also more effective than plain chemotherapy. And an example is CLL, chronic lymphatic leukemia, which is also some kind of indolent lymphoma. And there we already said farewell to chemotherapy, even in frontline therapy. And this is exactly the direction I am hoping for also in other kind of lymphomas.
So with all these new targeted therapies, immunotherapies, the future of lymphoma is looking better than you could have expected maybe when you started working on this.
Absolutely. The field totally changed. And We still have to be aware, to be honest, we are all human beings. We have a certain time where we can blossom and push the wagon forward, and then other people have to take over, the next generation. And this is what I also like about IHA. IHA is a young society. IHA is especially focusing also on the next generation. And that's really important. And a significant part of our members, around 40% or so, are part of this young EHA. So this is what I also really not only like but love about IHA, that it looks into the future, not only which direction are we going, but who is going forward.
And how can we support?
Absolutely. And that's also a lot of fun, to be honest.
So you have worked as a researcher, you work as a clinician, obviously, and you have been involved in all of these trials and in so many initiatives. What do you enjoy the most in your work?
This is a difficult question. And as you were saying, I was somewhat moving my focus. What I love about my work is really the mixture of it all. So I love also to give students courses. So I'm arranging the study of medicine in our institution. 2 people, 1 surgeon, one conservative medicine doctor, and I'm the conservative doctor. And I love to work in a team, also on the ward. I love to stand by our patients, trying to find the best way for them. And sometimes our treatment is only help, but it's just being with your patient. I love to do some research. As I said, I moved from basic research now more and more to clinical research, but clinical research is also translational research. If we're using targeted treatment, then we also have to be much more aware about the genetic alterations. So I think the whole package is a full bunch of flowers. It's so colorful, and me personally, I'm strongly believing in teamwork, but all these different aspects around, this is what it makes really great to work in the academic setting.
So at the end of the day, what you mean is that really all aspects are important, and they all can be enjoyed, and they have to come together. So you enjoy the fact that they come together.
Well, it doesn't have to come together for everyone. So everyone starts with a focus, and that's absolutely fine. It's same for me as well. But I love this profession because it's so colorful. Yes.
Well, thank you very much for sharing your career story with us, and thank you for all the contributions you have made to this field. Thank you also to all of you for listening, and stay tuned for our next episodes.